All right, welcome back to the channel. Today we want to look at the final method by which antibiotics have their effect. So we'll be looking at the mechanism of action. We've looked first at cell wall synthesis inhibitors. Then we've looked at protein synthesis inhibitors. Now we want to look at DNA. You must note here that for DNA synthesis inhibitors, we have two main ways by which they act. Those that directly affect the DNA strands, and those that indirectly affect the DNA strands by affecting substitutes or raw materials or nucleosides that are needed in the DNA synthesis. So the next group we want to look at are the DNA synthesis inhibitors. DNA synthesis inhibitors. So we will start with the first group, which is the quinolines, also known as the direct DNA synthesis inhibitors. They are the only group that directly inhibit this DNA synthesis. We will not talk about metronidazole now, but it's one that fragments the DNA strands that have been formed. And then the sulphonamides, trimethoprim, interferes with tetrahydrofolate synthesis in bacteria. So let's begin with the fluoroquinolones. All right, the fluoroquinolones, which basically are fluorinated analogs of nalidixic acid being the primary first generation quinolines. So we can see that there have been 4 generations of quinolines with various examples, beginning from the second generation where fluorine was added. They were now called the fluoroquinolones. And we can see examples like norfloxacin, ciprofloxacin or floxacin, levofloxacin, moxifloxacin, etc. So from the second generation downwards is where the floxacin rule works. For the first generation, we have cenoxacin, nalidixic acid, and ozolinic acid. Concerning spectrum of activity, the first generation are mostly gram-negative but have less activity against Pseudomonas. The second generation has an extended gram-negative activity, including Pseudomonas, and some gram-positive activity, like that of Staph aureus. Third generation, extended gram-negative activity, and some gram-positive activity. But in the third generation, the gram-positive activity is extended. And then finally, in the fourth generation, they have both extended gram-negative and extended gram-positive activity, but also has broad anaerobic coverage. Now, when it comes to gram-negative organisms and gram-positive organisms, these fluoroquinolones or quinolines act as direct DNA synthesis inhibitors. And 2 main enzymes are used depending on whether it's gram-negative or gram-positive. These enzymes bind directly to the DNA complex, and by doing that, inhibit the process of the synthesis. So 2 main enzymes are of interest here: topoisomerase 2 and topoisomerase 4. A topoisomerase 2 is also called the DNA gyrase. Now we should note that topoisomerase 2 is the enzyme that helps in the the DNA synthesis for gram-negative organisms, whereas topoisomerase 4 is the enzyme that helps in the DNA synthesis for gram-positive organisms. And one way we're able to just remember that is note that 2 comes before 4, the same way as negative N comes before positive. So 2 is to negative and 4 is to positive. 2 is the one that is also known as the DNA gyrase. Now, what about some pharmacokinetic properties of fluoroquinolones? Fluoroquinolones are well absorbed when taken orally, but in the presence of divalent cations like calcium, like magnesium, the absorption is impaired. So it's always advisable that these drugs be taken away from these divalent cations. For example, some antacid, magnesium trisilicate, magnesium sulfate, they all contain magnesium, or calcium hydroxide, which contains calcium, milk, which contains calcium. So we advise our patient to take it away from these things at least 1 hour to 2 hours before they take. They should not mix the two together. Otherwise, chelation will impair the absorption of the oral drug. When it comes to distribution, fluoroquinolones are distributed very well in the body fluids and in tissues. They also concentrate, especially in the renal system, and so very useful in urinary tract infections. Urinary tract infections. They are eliminated mainly by the kidney. And so a lot of times you will see they will affect, for example, Cipro will affect the color of urine. Your patient is supposed to know so that they are not alarmed. Thirdly, we should also note that it can precipitate out in the kidney, and therefore we advise our patients to take a lot of fluids when they take these drugs to avoid precipitation and crystal formation in the urinary tract. Clinically, we are using fluoroquinolones for infections such as eye infections, chest infections, or respiratory tract infections. We've used it in pneumonia. We've used it in tuberculosis. We are using it for GI infections like shigellosis. Urinary tract infections is one of its favorite use. Genital infections like gonorrhea, Cipro, and other fluoroquinolones have been used for that. And bone and joint infections. Part of its adverse effects is usually have GI effects, which is mostly common, nausea, vomiting, diarrhea. It's also been shown that it can damage growing cartilages and cause what is known as arthropathy, joint disease, which behaves like arthritis, inflammation of those joints. So, we ask that these drugs are not used in children unless under specialist advice, especially 11 years upwards. We actually advise that the drug should be used in 18 years and above routinely, if need be. Should not be used below those years routinely unless recommended by a specialist. We also want to note that the drug is excreted in breast milk, and so nursing mothers should avoid it because we don't want it in children. Nursing mothers should avoid it so that it does not get through the breast milk into the children and lead to arthropathy. The same way the drug should also be avoided in pregnant women. It's contraindicated in pregnant women. When used concomitantly with theophylline, the drug can lead to elevated levels of the theophylline simply by reducing the elimination of the trophylline through the renal system. And these elevated levels or concentrations of theophylline can result in side effects such as seizures in our patients. So that is fluoroquinolone, the first member that deals with DNA synthesis inhibition. Note that this one is a direct DNA synthesis inhibitor. Now let's talk about the indirect DNA synthesis inhibitors. The first member is the sulphonamides. Now, to understand sulphonamides, we have to understand how microorganisms make folic acid or dihydrofolate, a component that is integrated to tetrahydrofolic acid, which is used by microorganisms in the synthesis of DNA. Human beings cannot synthesize folic acid like microorganisms. Human beings have to take the folic acid as an end product in food or in medicine. But microorganisms are able to synthesize folic acid. And basically, these are the raw materials that are used: pteridine and PABA, para-amino benzoic acid, PABA. Now, when pteridine and PABA are combined by the activity of the enzyme dihydroteric acid synthase, also known as the folic acid synthase, this enzyme converts or combines these two to form dihydroteric acid. Dihydroteric acid is combined with glutamate to form dihydrofolic acid, which is then reduced by the enzyme dihydrofolate reductase to tetrahydrofolic acid. Now, it is a tetrahydrofolic acid that bacteria uses in its DNA synthesis, RNA synthesis, and also in some protein synthesis. So how do our sulfonamides work? Our sulfonamide works basically by competitively inhibiting the folic acid synthase, thus preventing the combination of the pteridine and the PABA. And basically, sulfonamides are made to look like PABA, and therefore they substitute PABA and as they substitute PABA, the enzyme picks it up, tries to combine it with pteridine, and the end product is not the tetrahydrofolic acid that is needed in DNA synthesis. So basically, indirectly, we are inhibiting the DNA synthesis. So basically, if you look at the picture here, you'll note that sulfonamides are made to look like PABA. So with the nitrogen group here, benzyl group here, the only difference you can see for sulfonamides with PABA is at the top here. And even there, it's very closely related. All right. So once a patient takes in a sulfonamides competitively inhibit the enzyme. And basically, when we say competitively, it means that together with intracellular PABA, they compete for the site of the enzyme, the folic acid synthase. So once PABA is taken, correct tetrahydrofolic acid is formed. But if sulfonamides are taken, then faulty tetrahydrofolic acids are formed. In the instance where faulty tetrahydrofolic acids are formed, then DNA synthesis, RNA synthesis are also impaired. All right. So note that it's a specific enzyme, folic acid synthase, that our sulfonamides inhibit. We classify our sulfonamides also based on the duration of action into three main groups. Now, first and foremost, we classify them as orally absorbable agents, Those are the agents that, when taken orally, can be absorbed. Then orally non-absorbable agents, which are the ones that taken orally are not absorbed. And then we have the topical agents, which are the ones that we put on topical surfaces, mucosal surfaces. Now, of the orally absorbable ones, this is where we look at our duration of action. We have short-acting, intermediate-acting, and long-acting. Short-acting ones act within 6 to 9 hours. They include sulfadiazine, sulfacytine, sulfamethoxazole, sulfizolazole. Then we have our intermediate-acting, which is about 10 to 12 hours, sulfamethoxazole, sulfamazole. Then we have our long-acting, which can be as long as 7 days, sulfadoxine. Where do we use these sulfonamides? We use primarily sulfonamides depending on the one we are looking at, orally absorbable, orally non-absorbable, or topical. We have used the topical ones, for example, in eye infections and skin infections, topically. Then we have used for GI infections. If it's localized, we could use the orally non-absorbable ones, and those are preferable because of side effects. Then if it is systemic, like meningitis, then we could use the oral absorbable ones. Urinary tract infection, we will also use the orally absorbable ones. Now here, like our fluoroquinolones, it's important that our patient drink a lot of water when they take these sulfonamides, also to prevent crystallization. We have used it in respiratory tract infections, also as orally absorbable agents. Leprosy, dapsone have been used for bowel disinfection, and this is where we are using mostly the non-absorbable group. It has been combined with other drugs also for other conditions like malaria. We have used sulfadoxine combined with pyrimethamine, and pyrimethamine also acts on the same pathway. So pyrimethamine inhibits the folic acid reductase, not the synthase. All right, and it's been combined with sulfadiazine for toxoplasmosis, especially in HIV patients. So that's our sulfonamides. Sulfonamides. Now, when it comes to their pharmacokinetic properties, sulfonamides are distributed widely in tissues and body fluids, including placenta, and it can cross over to fetus. It is metabolized by the liver as it goes through the liver biotransformation processes, usually eliminated by the kidney, and there's a possibility of precipitation. Hence, we advise that the patient takes a lot of fluids. So that is sulfonamides. Now, trimethoprim together with pyrimethamine on the same pathway of that tetrahydrofolic acid synthesis, we have the dihydrofolate reductase, folic acid reductase. Now, this enzyme is what is inhibited by trimethoprim, pyrimethamine, etc. So, it's on the same pathway, both leading to defective tetrahydrofolic acid synthesis and hence defective DNA synthesis. So trimethoprim is another example of an indirect DNA synthesis inhibitor, an indirect DNA synthesis inhibitor. It's pharmacokinetic, it's well absorbed when taken orally, distributed well into body tissues and fluids, just like the sulfonamides. may concentrate in prostate fluids, vaginal fluids, and therefore useful in those type of infections. So we use it mostly in those type of infections. So clinically, urinary tract infections is mostly where we use it. But we should note that because these individual drugs work on the same pathway, sometimes we can combine them. A sulfonamide can be combined with trimethoprim, just like uh, we see in Septrin or cotrimazole. So when you combine a sulfonamide and trimethoprim, that makes the drug usually gain a bactericidal activity. Individually, sulfonamides, trimethoprim are bacteriostatic usually in nature. But once they are combined, they become bactericidal by the synergistic effect that they confer on each other. A sequential blockade results in their bactericidal activity. They have been used for respiratory tract pathogens such as pneumococci, Haemophilus species, Klebsiella, etc. Clinically, we are using it in pneumocystic carinii pneumonia, shigellosis. We are using it in salmonella infections, urinary tract infections, prostatitis. This is where we have combined our trimethoprim sulfamethoxazole. Note that we are combining the tetrahydrofolic reductase with the sulfonamide, Good. Now we want to talk about the problem of resistance, because when we talk about antibiotic, it's always important to remember resistance, or antimicrobials is always important to remember the possibility of resistance. So let's look at the problem of resistance as far as the use of antimicrobials, and in this case, antibiotics, are concerned. We should know that all antibiotics can be resisted by microorganisms. Under the right conditions, given the right opportunity, all microorganisms can resist certain antibiotics. So, when we say a microorganism is resistant to an antibiotic, basically what we are saying is that that microorganism is not halted in terms of growth or killed by the said antimicrobial antibiotic. So the antibiotic that is usually killing or halting the growth of the bacteria, that particular bacteria in this instance is not able to kill. So in the presence of the antibiotic, the organism survives and even multiplies. Then we say that that organism is resistant to that particular antibiotic or antimicrobial agent. There are some bacteria that have developed resistance to more than one antibiotic, to many antibiotics. These ones are referred to as multi-drug resistant organisms or multi-resistant organisms. And these ones are very important to us because they pose serious public health problems. In fact, the problem of resistance is a public health problem. Now, if a bacteria that can cause serious disease becomes resistant to the normally used antibiotic against it, then we have a serious pandemic or problem at our hands. And interestingly, that resistant bacteria can be spread from person to person without the persons necessarily uh, being the first to develop the resistance. In other words, person A can have the resistant strain and it can be passed on to person B, either in the community or in the hospital setting. Could be a community-acquired infection or a hospital-acquired infection. So here are some important resistant strains that we have come across or that have been developed over the years. These are very important bacterial resistance that we are still dealing with. So methicillin, which is a penicillin that was designed for Staphylococcus aureus, we have some Staphylococcus aureus bacteria becoming resistant to methicillin. So you have methicillin-resistant Staphylococcus aureus. The same way, vancomycin, very good against enterococci, gram-positive enterococci. It's been shown that some enterococci have become resistant to vancomycin. So we have vancomycin-resistant enterococci. Mycobacterium tuberculosis, organism that causes generally tuberculosis in man. We've seen this organism developing resistance to the two strongest antibiotics that we use in TB. It's not only the we call it multi-drug because the two strongest, if it's able to develop resistance against even one of the two strongest, we normally use 4 or 5 medications in TB management depending on the one we are handling. We will talk about tuberculosis in another session or video. We also have carbapenem-resistant Enterobacteriaceae, which is another public health concerned bacterial resistance. It's been noted some of the ways by which we can help to prevent resistance to our antibiotics include minimizing the unnecessary prescribing and overprescribing of antibiotics. It's also important that our patients understand that once they are given a course of an antibiotic, it's very important to complete the entire course. And we should all practice good hygiene practices that will prevent infection in the first place. So, because if there's no infection, you wouldn't need the antibiotic and give the organism the opportunity to even become resistant. These are generally the mechanisms by which organisms develop resistance. So 3 main mechanisms. Organisms may have enzymes that they use to degrade the antibiotic or inactivate the antibiotic. For example, we have the lactamase, beta-lactamase, which organisms use to destroy the beta-lactam antibiotics. Organisms could also alter the pathway. We just talked about sulphonamides and the pathway. Organisms can alter the pathway either by altering the enzymes themselves or altering the receptor sites by which our medications work, or changing the pathway in another way such that our drugs are not able to interfere with the process the microorganism or the bacteria is going through. And like we said, for tetracyclines, some antibiotics are resisted through permeability mechanism, where the antimicrobial agent is not allowed to enter or it's forced out actively by the bacteria. So tetracycline is a typical example of our drugs that are resisted through the permeability mechanism. So in the face of resistance, we say that 3 very important things must be considered by the clinician before selecting an antibiotic. First, we want to select antibiotics based on individual patient. There are patients that are allergic to some antibiotics. There are patients that have complications with their kidney, with their renal system, their patients. So you want to be sure their kidney, the renal system, they are functioning well. So you want to know their functional level before you give antibiotics. You want to check what is the state of the patient in terms of if it's a woman, are they pregnant? Are they breastfeeding? Are there certain risk that can lead to complications. You want to be sure. So the patient is the first important person to consider or factor to consider before you prescribe or select an antibiotic. Secondly, you want to know what organism you are dealing with so that normally you can target that organism and not go in broad spectrum, and also helps in the selection of the appropriate antibiotic so that you do not necessarily kill the so-called natural flora. And then finally, you always have to remember that every antibiotic can be resisted by bacteria if abused. And so there's a risk of bacterial resistance when you are using antibiotics. So we should protect our antibiotics at all costs so that we can be able to do our battle with our microbial enemies or microbial disease-causing organisms. I shouldn't call them enemies, disease-causing organisms in one way or the other. All right, thank you very much. The Lord bless you indeed, cause his face to shine over you and give you peace. Please don't forget to subscribe to the channel for updates as they keep coming. Have a wonderful rest of the day. God bless.